This is Roger Green, host of the Surfing the NASH Tsunami podcast. This week we're offering 4 conversations from episode 59. Our review of the recent Nature Reviews Gastroenterology and Hepatology paper titled Advancing the Global Public Health Agenda for NAFLD. I begin this conversation by referencing Ken Cusi's recent discussion of the multi-specialty clinical care pathway driven by AGA and other specialties on episode 49, and Scott Friedman's discussion of the environmental influences on microbiome and health. Jeff Lazarus notes that environmental and healthy eating groups can play a significant role in changing behavior by changing environment. He also praises Ken and that group's work on clinical care pathways. The discussion turns to discuss how bleak the future might look if cirrhosis continues to grow at such a dramatic rate. Comments from Louise and me support the idea that liver risk might double in the next decade, plus minus 2 years, if we continue at the current rate. Jeff goes on to discuss how imperiled our futures might be if we do not act now. In the end, group members discuss the places they believe action will drive the broadest, fastest, most durable impact in the world. This global health agenda has been endorsed by medical, governmental, and patient advocate stakeholders around the world. Its results and insights have the potential to shape the global NAFLD dialogue from here forward. So sit back, listen, enjoy, learn, and when you're done, join the dialogue on our LinkedIn and Facebook discussion group. We've had 2 conversations on this podcast in the last couple of months that bear on this issue in 2 very different ways. First of all, Ken Cusi came on, I guess, about 2 months ago, really, to talk about the clinical care pathways paper that was published in Gastroenterology that was the work of multiple specialties, coordinated, I guess, under the aegis of the AGA, that he was the lead author on. I think, Jeff, that touches on a lot of the points, at least in the state, not that it's gone anywhere yet, but the kind of model that you can build in this system that makes sense. It was a pathway. It had steps. It was, this is what you do, and then this is what you do, and then this is what you do, and the reason everybody should care. So foundationally, on the medical side, I thought that was really interesting. As I was listening to you today, I was realizing that those 2 might interlink in some ways. That what you're talking about making happen, that's an effort to begin to make happen, at least in the States. That was number 1. Number 2 is Scott Friedman was on during ASLD, and he characterized NAFLD as an environmental disease. His point being, we've had, people have been around for tens of thousands of years. Our genes don't change very quickly, and yet in the last 35 years, this disease has taken us by storm, and what's changed in the last 35 years are eating habits. And eating habits affect on the microbiome, and as we learn more about how the microbiome interacts with neuronal systems and other things in the body, that's a pathway that merits a lot more attention than it's getting right now. Louise made an offhanded comment to me on a side note last week about we have to think about this as an environmental issue also. Now, I don't think that was exactly the same thing, but the points I think are related. There are policy issues around how we think about food and our ecosystem in terms of what people eat that clearly come into play when you think about this disease. Just thoughts about either of those?
Jeffrey Lazarus.
So that's one of the things that actually gives me hope, even though it's a big challenge to address the entire environment and what we're eating at the same time. But I mean, it does mean that we have allies in groups that are trying to protect our climate, in groups that are trying to work for healthy eating, because that's how we're going to really change things in a big way. It's going to end up being a bigger difference than the individual behavior change, although I think that's also important. And, in the work that Ken Cusi led and that pathway, it's remarkable and it's tangible, and that's what we're going to need more of. And a lot of that's going to come at the national level too, because our health systems in Europe are so different and it's so heterogeneous. We're going to need to understand what needs to be done at the primary care level. How do we engage with endo? How do we engage with other comorbidities and other colleagues, and who's going to be paying for it? What you suggest about our allies, it's like what Louise was saying with the SDGs. I mean, we need to think big. I mean, this is a big change. Stephen's absolutely right. This is the canary in the coal mine. You said one big change we've had has been our eating habits. The other big change, of course, is sedentary lifestyle, which has gotten a lot worse during the pandemic. And then the other big change is much more positive, which is that we're living longer. The good thing about the liver is it takes a long time before it conks out, but we're also living a really long time now. As WHO said, mortality is 100%. We're all going to die of something. The question is just what? We could get a lot more time if we address liver health, and now we're seeing what's going to happen. When Stephen was talking about the importance of data, it made me think of the modeling that the Center for Disease Analysis, Chris Estes, Homi Razavi, and others, and partners in countries have been carrying out. Because when they look at what's going to happen in terms of F4 cases in 2030 due to fatty liver disease, you get a doubling, tripling, or quadrupling in the countries that they analyzed. I realize modeling is a very powerful tool, and we need to do more of it. I realize it's modeling, and it's based on a lot of assumptions, but the future looks quite bleak if we don't do anything, and that's the kind of messaging we're going to need to get to policymakers, combined with the kind of costing, for the work that Jörn was leading, so they can see the cost of inaction.
Louise Campbell.
That's what struck me in the piece, was that doubling and tripling of compensated and decompensated cirrhosis, because that's immediate. That's in the next few years. And our hospitals are certainly not configured for that level of patient illness coming through. So unless we, as policymakers, unless health purchasers really start to look at these figures, cirrhosis is increasing over 10 to 15% per year in each hospital. So we just don't have the resources to look after and care for these people appropriately. And that should never be a state of lack of knowledge, to be able to offer somebody the best care available in your local trust or local hospital. And that's where the immediate liver risk is, for me, is the quality of care and outcomes that these patients are going to get in the next 15 to 20 years, unless we actually start to change it now and wake up.
Thanks, Louise. Let me just interject quickly before we go on to a couple more comments. I want to give our audience a gift. The gift is called the Law of 72. It's a very simple statistical rule that you can use in situations like this, which is you take a number, you divide 72 by that number, and that will tell you how fast the incidence of whatever you're looking at will double. So let's say that the cirrhosis number is 12%, for example. Law of 72 says you take 72, you divide it by 12, and you get 6, and that says doubling in 6 years, which says quadrupling in 12 years. So if you want to understand roughly what happens if nothing changes, it's my gift to everyone who listens to this podcast. Use it wisely, use it often, and when appropriate, scare the stuffing out of people with it. Like, say, that example. Jeff, Jörn, go on. Comments, thoughts?
That's the point, is that look at how quickly things are going to get so bad. I mean, it sneaks up on you. I mean, in cirrhosis, well, it sneaks up in years, not months or weeks like the current COVID pandemic, but suddenly before we know it, liver cancer was the second leading cause of DALYs of all cancers, and people seemed really surprised. Everyone in hepatology knew it was coming. We might not have known the exact numbers, but we were thinking, well, it's going to be number one day. And like I said, with the modeling study, by 2030, things are looking pretty bad, and we're about to end 2021. And that was really, to go back full circle, that was the impetus of the consensus statement, was to take that public health approach and say, in the face of this major challenge, there's a lot we can do, and there's a lot of allies and potential allies out there. But right now, we're almost at ground zero, and in 2022, we really need to turn that around, and we need to work to not just get it into WHO documents, to get it into one of the WHO official days, the way we did with hepatitis and HIV and malaria and TB. We need that attention. We need the World Health Assembly. So whatever one thinks about WHO and its assembly, in the end, it's governed by its member states, and we need those member states to recognize at an assembly meeting in May each year that fatty liver disease is serious, and even if they call for a strategy or an approach or a framework some years down the line, that they at least acknowledge now that we are going to need it.
Thanks, Jeff. Jörn, you have a comment, or we'll go to final question?
Jörn Schattenberg.
Yeah, I guess my comment is that really, and this is where the expertise of Jeff and the public health care research field comes in, that we get policy makers to consider this as a disease that needs a strategy and an outlook. I've mentioned funding independently for universities, but you've got to come up with a plan for your healthcare system. And there are disease management plans in Germany, and I'm waiting for the day that we have the term liver in there in an obesity package or an obesity care path. We got to, at that political level, grow this together, and that's far beyond what I could achieve as a physician, and this is where the public health agenda experts come in. I think that's why I'm so happy we're at this point.
Well, okay, Jörn, thanks for that, and I think that's a great comment on which to go to final comments. I already gave you the question, right? One place where you think we need to have the greatest impact, and one place where we can have meaningful impact quickly in this entire panoply of issues discussed in the consensus paper and everything else we've talked about today. Stephen went first, so brave one goes second.
In Germany, you're settling up with a new government here, and healthcare officials are being formed and panels are being formed. So I'd really like to reach out and be in touch with them based on this type of work and contribute to these policies that will be making up the next 4 years of German healthcare. And of course, even longer, because the problem's real. It's there. It's the money. It's costly. By looking at it from a public health agenda, we can define the need here.
I'm going to jump in next to give Jeff the last word. Not dissimilar to yours. Here we're looking at more integrated care pathways. We're looking at diagnostic hubs being set centrally, and FibroScan and non-invasive technologies were advocated in there. But they'll only get there if commissioners understand that the liver is actually an important cost to them and to the patients within their region. I'm happy to go and scan every commissioner in the country to show you what your liver health is like, if it takes you to understand your own liver health. But we really need to have liver higher on the agenda in the commissioning hubs and for who's purchasing healthcare to get out there to have a look at liver health, because everybody I know now knows somebody who's got liver cancer, and that can't continue.
Sadly, it probably will. I will let Jeff have the last word, which means I'll go next. This is a terribly male and terribly pugilistic view of the world. But one way to think of this particular enemy is if what you were talking about is boxing. And the left jab is the non-communicable disease and what it does to the overall metabolic system, diabetes, heart, etc. And then the uppercut is actually liver cancer. So if the jab hasn't taken you out, the liver cancer will cause a demon of a problem for you. It's hard for people to get two thoughts into their mind at once, but here I think it's pivotal. So I'm guessing smarter people with me who've got much better visualization powers will come up with a better way to characterize that. But that really is the point. It's both the jab and the uppercut. And I think if we understand the role that both of them play in the scale of this issue, it'll be easier to get people doing the things they've got to do. And with Jeff, my friend, last word's yours.
Thank you so much, Roger, and thanks, Louise and Jörn, for this discussion. It's been so important and enlightening. I like the boxing analogy. I would say the inflection point for me is that we're going to need to see modeling beyond 4 or 5 or even 10 countries so that we can see just how bad this is going to get, and again, how much it's going to cost to really get policymakers to react. We've seen how slow they react on so many issues. But now, like you said, Louise, so many people have liver cancer. We need to find allies, unfortunately, among those important people who, and spokespeople who have had liver cancer or have had someone close affected to them. The patient groups are incredibly important, but they are quite weak in most countries. So we're going to need to strengthen our ground. We're going to need our foot soldiers, the patient advocates, the patient groups. It's going to take you hepatologists and other liver health experts to work with them and to build that army to raise awareness about how serious a condition is. And like you said, Roger, it's going to be a left jab, it's going to be a right uppercut, but in one way or another, the liver is going to get a lot of people, and it's going to get a lot of people by surprise. And with the numbers we have projected to 2030, it's going to be a major public health problem, not just because we said it is in 2021, it simply will be.
Well, I have one more question for you. This is a U.S. question. Everybody who listens to this podcast regularly has been beat to death appropriately with the data from the 2 San Antonio Medical Military Center studies that Stephen did in 2011 and 2021 that suggested among a group of walking around people in their 50s in San Antonio who thought they had no cause for pain or concern about their livers, that 37% had NAFLD, 14% had NASH, and in the latest round, 6% had F2 or greater, which is the one number that had changed over the 10 years. It was 2%, now that's 5.9%. I shared those numbers with a public policy friend who said you can never let those numbers get out. And I asked why, and the answer was because even at 20 to 25, the numbers we're using right now, people who have to pay for this are scared to death. And if you give the numbers that are any higher, the odds that they're just going to stick their heads in the sand and deny the problem becomes infinitely greater, particularly private sector payers in the U.S. I'm wondering whether there is a risk that if we amplify the problem to its true scale, we start to scare people away or get them to throw up their hands. And how do you see dealing with that?
I think that's a really good point. And I do think that that is a real problem. I mean, if we cry pack of wolves and there's only a wolf, people aren't going to listen as carefully. I think we need to be very careful not to overestimate the numbers. That was a big problem with HIV. It's a problem with hepatitis C, and it's a lingering problem because it looks like things got a lot better when they actually didn't get a lot better, at least in terms of mortality. They got a lot better in new models of care, or more people aware of the treatment and better prescribing and so on. So I do think it's an issue. The numbers are high enough now to worry people. We need to appeal also to, on the one side, the economics. For those in the US, that's a real issue, the cost of inaction. And in Europe, there are value systems we need to appeal to in addition to the economic arguments. But we need to avoid exaggerating the issue. We need to talk to our allies and say that this is going to make the diabetes worse. This is going to cause more CVD. That we know. And we don't need to exaggerate the numbers of people with fatty liver disease, but we know that there will be serious issues with the comorbidities in addition to the own mortality through liver cancer and end-stage liver disease.
And now, back to Roger.
We hope you have enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. We will be back next Wednesday, December 15th, with our next episode in which we review the Splendor study on bariatric surgery and the impact of related weight loss on the liver. If you want to join the live audience Monday, December 13th at 3:15 p.m. Eastern Time, email surflive@surfingnash.com, that's SURFLIVE, with the request, and we will send back a link to serve as your admission ticket. Or simply look for our invitation post this coming Friday. I hope you join us then, either live or on the podcast. Until then, stay safe, surf on, see you on the podcast. Bye-bye now.